Let me invite our next speaker, Dr. Milhan Batcha, consultant fertility specialist attached to Castle Street Hospital for Women, to deliver a lecture on male and female fertility preservation, especially with regard to cancer treatment. Over to you, sir.
Good afternoon. Thank you, Gayani. First of all, I thank FPA for inviting me for this session. The topic is fertility preservation. So, fertility preservation becomes important if an individual is going to lose fertility because of diseases or sometimes because of treatment. Majority due to treatment. I have nothing to disclose. So, the field of fertility preservation has grown immensely for the last 2 decades because of increased recognition of this problem. Also, development of enabling technologies. A person's reproductive capacity can be reduced, majority due to age. Basically, majority in the female. Luckily, the males, they retain their fertility for a long period. The other thing is gonadotoxic treatment. Chemotherapy, radiotherapy, etc. can cause gonadotoxicity and reduce, or sometimes they will lose their fertility, especially when it comes to treatment for malignancy. Certain other disease conditions, including some genetic problems, can lead to deterioration of the fertility, and also surgery, abruptly, somebody have a oophorectomy or something, orchidectomy, certainly can lose their fertility. When the future fertility become compromised, the fertility preservation become a fundamental thing for them. And in females and males, both it can happen in the reproductive age and also for pre-pubertal girls and boys. So what are the indications for fertility preservation? As you know, malignancy is the chunk of the problem. More and more young cancer survivors, with the advancement of treatment, they survive. Ultimately, they would like to have a family. So most of the time, if they recover from the cancer, by the time when they come out from the disease, they want to have a family. They may not be able to do it, or if they lose their fertility. So these are the patients' majority. Other thing is, majority of these patients, by the time when they come to us, already they may have reduced fertility because of the disease itself. But major problem comes with the treatment. That is the chemotherapy and the radiotherapy. Chemotherapy is concerned basically the alkylating agents. Now, apart from this fertility issue, when somebody lose their gonadal function, the other problems comes into play because the gonads secrete hormones. So then it can have effect on the pubertal development if they lose their gonadal function. Normally we need hormones, reproductive hormones for our normal day-to-day life and for the sexual function that can affect by this treatment. There are a lot of non-oncological conditions requiring fertility preservation. Lots of autoimmune disease comes into the picture. The autoimmune disease itself can impair the fertility. Apart from that, most of these autoimmune conditions need cytotoxic treatment, so that can affect their fertility by the treatment. And certain medical conditions like benign ovarian tumors, when you remove ovarian tumor, ovarian cyst or something like that, then with that you will lose a lot of ovarian tissue, especially like endometriosis, multiple surgeries can remove the ovarian tissue, things like oophorytis, so that ultimately they might end up with premature ovarian failure or reduce ovarian reserve. Certain genetic conditions like mosaic Turner syndrome, they will lose their fertility early, a fragile X syndrome, galactosemia, even beta thalassemia. So we will see their fertility drop to early stage, and Klinefelter syndrome in the male. And other things like hematopoietic stem cell transplantation. Before the transplantation, they need eradication of the pre-existing bone marrow. For that, they use chemoradiation. So ultimately, they end up with ovarian or testicular failure. So other aspect is age. As you know, when you go older, the fertility declines. So people, because of their socio-economic reason, they delay their pregnancy or the marriage. And as you know, the female fertility decreases gradually after 32 years and faster after 35 and 37. By the time when they reach 42 years, very unlikely to get pregnant. So what are the options available for us? For the females, I would say oocyte cryopreservation is, one of the first line and well-established method right now. It is increasingly preferable method because it gives autonomy to the female. Because the thing is, you don't want to have a partner or getting married, so you just freeze the eggs, then subsequently you can utilize it without any problem. So only thing is, when you collect eggs, we just doesn't want one egg. We would like to have about 10-15, if possible 20, because that gives a good chance of pregnancy subsequently. And for that, they have to undergo a controlled ovarian stimulation protocol using gonadotrophins, that is FSH. Most probably we use an antagonist protocol. It will take only about 14 days. So we need some time for that. If somebody diagnoses cancer, if you have 14 days, we can go through a cycle and get eggs out and freeze. So the technology is vitrification. That's called fast flash freezing. So when it's human egg is the biggest cell in the body, and it has a lot of water content. If you allow it to slow freezing, the ice formation can destroy the egg. So this flash freezing technique is the key of success. So that has made this survival better. Right. There are some instances you won't will be having that 14 days of stimulation. So another thing what we do is for these patients, we can get the immature eggs out. Whatever the eggs they are in the ovary, you can see when you do a scan, there are small follicles. We can aspirate those ones. Then you get immature eggs. But the thing is, you can't just freeze these immature eggs. We have to do the in vitro maturation. So we mature this egg and then we get mature oocyte and then we freeze. So that gives us a chance. Only this is allowed. I mean, we do this one only people who can't have these 14 days of stimulation and really they want to have the egg freezing. But for this, we need special technology and culture medias, etc., and the proper trained people. So that is the kind of a thing. That's why it's not always we don't do, because we prefer to do the mature oocyte cryopreservation. The other one is, as everybody knows, embryo cryopreservation. This is possible somebody who is already married or having a partner, and this is the most established option earlier, and it's a part of IVF, normal IVF program. If you have surplus embryos, we freeze. So again, the vitrification, that's called this flash freezing, allow almost 100% survival. So the survival is pretty good. So not to worry people when you freeze embryos nowadays. So as I said earlier, it's possible only unmarried or who having a stable partner or willing to use donor sperm otherwise. But the thing is, we know cancer treatment takes a long time, sometimes to recover and come. So by the time they recover and come, sometimes the family will not exist. So in that case, there will be a problem with utilizing these embryos and their legality. So that's why I said earlier, the first line option would be egg freezing. There's another technology what we use is, this is a newer, not very new, the ovarian tissue cryopreservation. That is, before starting cancer treatment or whatever the cytotoxic treatment, we get the ovary out of the body and freeze it. So after that, subsequently, once they finish their treatment and they are clear of cancer, they can come back and transplant this ovary tissue back to the system. Actually, this is recommended for people who are undergoing moderate to high risk toxic treatment, where we can't do for various reasons oocyte cryopreservation or embryo cryopreservation. This is the only option for pre-pubertal girls. Still, we can take these ovaries out on them and freeze. And as I said earlier, when somebody is diagnosed with cancer, they want to start treatment quickly as possible, so they don't want to wait. So if they don't have time to wait, of course, we can take the ovaries and freeze. Other thing is, this is not only a fertility preservation option. So when you put back the ovary to the system again and start producing follicles, the hormones become normal. So that's the other advantage you have with this method. The first pregnancy after ovarian tissue cryopreservation and subsequent transplantation was way back 2004. Then immediately in 2005, the second one. And after that, it's just surged up. I think right now there are about more than 200 reported cases, but there are lots of unreported ones. So I think it's very commonly practicing now. So what is the technology we use? So usually what we do is we harvest this ovary by using a laparoscopy, take the ovary out. Usually we try to remove only one ovary because, as you know, normally when somebody goes to chemotherapy, we can't predict how much they will go for premature ovarian failure. Some, after about 2-3 years, they recover. So if you take one ovary and keep one ovary inside, still sometimes it can recover. Sometimes they might get pregnant naturally. But still they have a chance to, if they go through premature ovarian failure, still the ovaries are frozen, so they can get pregnant after that using those eggs. So that's why usually we take only one ovary. But if somebody is going through radiotherapy, of course, I would recommend to take both ovaries out and freeze. What we need is only the ovarian cortex. So what's the thing what we do is, we take the ovary, cut it, and take the medulla out, take only the cortex, make small pieces, 2 millimeter to 3 millimeter, 4 milliliter, and freeze. So the freezing technology, again, there are two methods I said earlier, vitrification, that is the flash freezing, or the slow freeze. So nowadays, still the best technology is the slow freezing, and the success rates are better with slow freezing than the flash freezing for ovarian tissue cryopreservation. Once the patient is clear from the disease, they come back, then we put those ovarian tissue pieces to the position where it was taken. So it can be done either, now I said earlier, we will remove only one ovary, the other ovary will be there. Sometimes the ovary goes into kind of fibrosis, and you cut that ovary and expose to the vasculature. You need to have vasculature, otherwise once you put the pieces, it will not grow. So make sure there is enough vasculature is there, and then you can suture it. Otherwise, sometimes you can put the interseed and cover it. Otherwise, you can put it to the same place where retrieve the ovary, but you have to dissect to the peritoneum and put it. There are other methods also. What you need is eggs. So even if you can put under the skin and then it allow to grow and take the egg out, still you can do it. But nowadays, still the success rate is better if you do this technique, because I don't know why it is, but normally the success rate is higher if you place where it's supposed to be there. Okay. And what is the efficacy and the limitation? Ovarian activity is restored in more than 95% of the cases. Some studies have shown that means when you put the ovary back, start producing egg, hormones become normal, then the all menopausal symptoms disappear. So this happens almost 95%. The mean duration of function of this ovarian ovarian tissue can vary from 4 to 5 years. So it's not going to be normal as the normal ovary. And some studies have shown even 7 years they were persistent. These are one of the studies, 445, large number of cases, and before various indications. This was between 1997 to 2013. The mean age was 22. They are very young people they are used. After the procedure, some of them have died, 54% by the time. So that's why, although they freeze their ovaries, they may not be able to utilize it. 25 of them have come back for treatment, again to put the ovaries back, and 21 had their ovarian transplantation. 7 got pregnant in this particular study. 68.5% have that got normal in their hormones, and 31 still didn't get. There are reasons for that, so I'm not going to talk in depth of those reasons. And also this review showed a very high satisfactory level, because that's 96% of the patients were very satisfied about this procedure, even those who did not require reimplant, because addressing their fertility issue before starting cancer treatment give them kind of a positive psychological impact, because they know sometime, cancer treatment, when somebody is diagnosed with cancer, they have to go through so much, and if they know that they can't get pregnant even after the treatment, they are disasters, that they will be like devastated. So if they know that, if I come out of the problem, if I can have a family, then they'll be facing very positively for their treatment. So that gives kind of a sense of hope. So that actually play a very positive role for their recovery. So when it comes to age-related fertility decline, because nowadays people are trying to delay their pregnancies because of the carrier and various reasons, I would say the best option is to use oocyte cryopreservation, and also for non-oncological condition. Sometimes for cancer patient, we do another thing, so combined technique, because if they have time, we take the eggs out, and same time we take the ovary also, freeze that also. So then combined FERT will give a very high pregnancy rate. So that's we do. Even we in Sri Lanka we do that one. Another thing is, if you don't have all these things, we sometimes recommend to give GnRH agonist pre-treatment before starting cancer treatment. GnRH, if you give to a person, the ovaries they go to kind of a menopausal thing. The ovaries, the primordial follicular development ceases, and then their sensitivity to damage by these gonotoxic agent will be less. So that is the theory behind that. But it doesn't have much evidence. But thing is, if you don't have any other option, this is another thing you can do before starting cancer treatment, especially chemotherapy. Another method people used to practice from good old days is ovarian transposition. That is, bring the ovaries away from the radiation field. So if this is possible only pelvic cancer, where you can give only radiotherapy. If you give chemotherapy, it's going to get destroyed. So only if radiotherapy can cure the patient, then of course taking the ovaries out will help minimize the damage. And subsequently, even if you take from the tube, it's tube also with that. People have got pregnant naturally after that. But sometimes it's not, then you have to get them back down, because if you want to go for IVF also, then of course you have to bring the ovary back again to the normal position. So these are the kind of options we have for female. What about males? As you know, everybody, sperm cryopreservation is the only established fertility preservation method for adult and adolescent male. But the problem comes sometimes when the people are very ill sometimes. In that case, and they are psychologically, they are mentally, and they are physically, sometimes they may not be able to produce sperm during these illnesses. So in that case, sometimes you need assistance to get the ejaculation done. And for that, sometimes you use electric vibrators, or sometimes electroejaculation, or sometimes even you can do it by surgically as well. Another technique what we use is testicular tissue cryopreservation, like ovarian tissue cryopreservation, but the success rate is not good as ovarian tissue cryopreservation, so still it is experimental. To summarize things, fertility preservation is a fundamental thing. If somebody wants, it has to be provided and give hope for cancer patients. So embryo cryopreservation and oocyte cryopreservation are well established option for females, and ovarian tissue cryopreservation is no more considered as experiment. It is done and been proven. Ovarian tissue cryopreservation not only helps to have the fertility preserved, and also it normalizes reproductive hormones once it been placed back to the system. For males, sperm cryopreservation is been practiced for a long time, and testicular tissue cryopreservation is still considered as experimental. Thank you for listening.